Thank you for joining us. My name is Theron Steinke, and I am honored to introduce you to our team of clinical educators and local prosthetists and orthotists. It is our firm belief that patients living with limb loss receive the best outcome possible when we take the team approach to their care. The relationship between the prosthetist, therapist, physician, and other treating medical professionals starts and ends with open communication and education. We learn just as much from you as we hope that you learn from us, and it is our goal to make these presentations a conversation, not a lecture. We sincerely thank you for your support and devotion to this specialized patient population.
Hi, my name is Renée Veld, and I'm a physical therapist. I work for an orthotics and prosthetics company in the Midwest. I do a lot of education presentations to both practicing therapists and students, as well as consulting with our practitioners for patients with lower extremity amputations. I worked for over 20 years as a physical therapist at a level 1 trauma hospital locally, mostly in the outpatient department, treating patients with amputations as frequently as possible. I also taught in a local DPT university program for 14 years, teaching content on wound care and amputations, as well as serving as the director of clinical education. Now, my passion is continuing with education. I like to help as many people with amputations as possible by training therapists. I enjoy training therapists who have been therapists for a long time, who treat amputees routinely, as well as helping people who don't treat amputees very often to feel comfortable with this content. I want them to feel like they have the words to ask the right questions of their local practitioners for best patient outcome. Hi everyone. This presentation is focused on post-acute care for patients with lower extremity amputations. By post-acute care, I'm thinking of all those possible settings where a patient may go after they leave the acute care setting. Could be inpatient rehab, IRF setting. It could be a skilled nursing facility. It could be home health. It could also be outpatient pre-prosthetic. All of the things I'm going to talk about in this presentation apply to any one of those settings. The degree to which you will apply these interventions are dependent on the patient's progress, just like any other intervention we might provide. So there's your course description that is in the handout for you, and here are your course objectives. So we're specifically going to talk about edema. We're going to talk some about phantom limb pain, sensation management, a little bit about exercise and positioning, a little bit about transfer training, and then we want to talk about progression to the prosthetic phase. That's a lot to cover, so I'll try to be as succinct as possible and plant some seeds for you to follow up later. If you have also seen the presentation that I've done on acute care for patients with amputations, this is going to look very similar. There's a whole lot of overlap. And I also understand that all the things I talk about that you could do in acute care don't always get done in acute care, which leaves it to you post-acute care folks in the pre-prosthetic phase to really start on that path of getting somebody ready for prosthetic limb fitting. So don't be discouraged if you see some of the same things, just understand that we're talking about a progression here. So I always start with talking about compression. I kind of preach this one from the mountaintops because I think it's so incredibly important. If someone comes out of acute care with no compression or minimal compression, that's usually going to be a big post-op dressing with ACE wrap over a whole bunch of Kerlix. And that's what's true for most patients, trans-tib or trans-fem. Then we in post-acute care can be even more assertive with starting some level of compression. So I think most of these bullet points you know. Some kind of edema control is necessary because we've got to get limb shaping for prosthetic limb fitting. You can't fit a prosthetic limb if there hasn't been any attempt at managing edema and shaping the limb appropriately. Good compression also helps with pain control, localized pain control, and phantom limb pain. That's another bonus that I don't know if surgeons are always thinking about. The best scenario is getting medical level compression as soon as possible for the patient. That's really what we're looking for. I think when we get down to the bottom of this slide, that's where things get a little stickier. Sutures and staples still being in place do not prohibit compression. It depends on the patient,
depends on the surgeon. Don't presume. Ask. There's no reason not to ask if it's okay to go ahead and add compression. You have learned appropriate application of compression in school. We all learn that. That's baseline for physical therapists for sure. And I know occupational therapists address it too. We can look at a limb and say, oh, I think that's okay, taking all of the other information into consideration for compression versus, wow, I wouldn't compress that. That doesn't look like it's healing very well. Those are things we know already. So starting that conversation is absolutely in our wheelhouse to do. How you place compression over sutures or staples might be a little bit different, but it doesn't mean that it can't be done. So I like to let therapists know that I very generally separate amputee patients into two categories. The true vascular patient, arterial disease, large vessel disease, and the orthopedic patient. So even though we would consider diabetes to have vascular component, of course, a neurovascular component, once they have an amputation, if that all went well, now they're an orthopedic patient, unless they have some other comorbidity that's arterial in nature that would limit our ability to apply earlier compression. So I treat them in that way. Obviously, the trauma patients are going to fall into the orthopedic category as well. We could be a little bit more assertive in applying compression a little earlier, knowing that that's going to help the outcome. And it may fall on us, especially in outpatient or at post-acute care, to follow up with the surgeon. Patients going back for a post-op appointment next week, I'm seeing the patient in a SNF setting or maybe in home health. I'm going to send a message with the patient or send a note to the mid-level provider to say, hey, I think the patient's ready for a shrinker. Can we go ahead and move forward with that? That's not a wrong thing to go ahead and address that early on in the process. So let's talk about types of compression. We start with ACE wrap because that's what we're seeing the most of. I won't spend a lot of time on this in your setting. Suffice it to say, I don't like ACE wrap. That's not a big surprise to anybody who's talked to me for any length of time about compression. There's so many reasons why it's not the right thing for people. The benefit is it's cheap. You can take the dressing down, look at somebody's residual limb, inspect the incision line. That's really a minimal benefit. In your setting in post-acute care, you're the ones who are really going to be working with people about applying compression themselves. So you're now in a position to try to teach somebody how to wrap their own residual limb, and it is not easy. So keep that in mind when it comes to using ACE wrap. This is where I really want to move into talking about shrinkers. If somebody comes out of acute care and they don't have a shrinker yet, it might be on you to go ahead and move forward with that. Again, please don't wait for somebody on the medical side to think of it. It's not that the surgeon doesn't mean well by the patient. That person might forget about when to apply compression. Maybe they don't know. And number two, they're worried about healing. So they're more concerned about was my surgery effective, and not always thinking about the long view for the patient. I think we can advocate for people by going ahead and asking for some level of compression. And that's when a shrinker comes in. So I do like shrinkers a whole lot better than ACE wrap. They're much easier to put on for a lot of different reasons. Not all that wrapping. You don't have to worry as much about sitting balance, etc. More consistent compression. And the one drawback is that you need an order for it. This is a medical device. And depending on your setting and what the situation is with the patient's insurance, that may go under a group. Like in acute care, it'll go under a DRG potentially. You might also be needing to get a PO. If you're ready for a shrinker, you want to recommend that. Talk to the local practitioner, your prosthetic provider, about the insurance piece of it, and they will clue you in about the paperwork that they need in order to make this happen. So I wanted to briefly review the kinds of shrinkers. So in the top picture, you'll see this traditional shrinker. This is really transtibial, not transfem. I've seen people try to put these on transfem patients. It just rolls down, it bunches up, it's ridiculous. It's almost never going to work unless somebody's thigh is truly straight up and down, which doesn't happen all that often. So you'll see in the picture, the first layer goes several inches above the knee. Then you get to this, and it needs to be smooth, no wrinkles. You get to the ring, you push the ring up to the end of their residual limb, and then double the second layer over. And the second layer can come above the knee, but if there's too much bunching in the popliteal space, go ahead and bring it to the tibial tubercle. That gives us gradient compression, which is what we're looking for. So for the trans-tib patient, we don't have to worry so much about length. For the trans-fem patient, we do have to worry about length because we want to make sure there isn't any space in the bottom. We want this to fit flush to the patient's skin, or you'll have edema collecting in the distal end of their residual limb. So this is a traditional trans-fem socket, like in the picture. This needs to go all the way up to the pubic ramus. It's kind of soft, so people seem to prefer that. And then there's the dreaded hip spica, which no one likes, can be really irritating, but it holds it in place. You gotta have it with this kind of shrinker. I do want to share with you an alternative, something the company I work with is using more now, and that's a shrinker that looks like this. It's more like a compression garment that I'm used to from treating patients with lymphedema or other edema issues. Here's what the top looks like. It's silicone beads, kind of nice. That's how it stays up. No doubling over, single layer, a whole lot easier to manage. Flat seam. So we're not going to irritate the incision line. This comes over the knee for the trans-tib patient, can also apply for the trans-fem. I really love it for trans-fem patients. No hip spica. This comes up to the pubic ramus. They've got to capture that medial tissue in the proximal thigh to make sure that the limb is being shaped properly. Talk to your local provider if this is, to see if this is a brand or a kind of shrinker that they use or would ever supply. You might have a patient where you as the therapist are the one who's making the recommendation of type of shrinker based on the patient's ability to don. Work with your OT colleagues on donning and doffing shrinkers, making sure that they're also participating in this decision making. What's really going to work for the patient so that you don't get them something that just never works for them and they're unable to use it. When they get shrinkers, they get two, one to wash, one to wear. It needs to be applied by a certified or licensed prosthetist. You can tell how I feel about shrinkers. And the last bullet point is that patients have a choice of practitioner. So I'll talk about that a little bit more here in a moment. Okay, I also want to talk briefly about another option. So let's say somebody's a lower level patient. This might apply more in a SNF setting, possibly in patient rehab or home health. I feel like the patients I've encountered at post-acute care who really needed this were patients at home. And maybe they were getting home health. This device that's in the picture that I have is called the Rook. That's a brand name. Your local provider might have another version of this that they use, some other kind of stump protector. The order should say transtibial or BK stump protector. We call this the Ugg boot. It's nice, soft, and fluffy. It is washable because it can get kind of messy if patients are still healing. The bottom of it is really thick foam. So this is how thick it is. It's fantastic. So for the trans-tib patient, when they fall, guess what they do? They reach their leg out. They're going to fall on their residual limb, break it open. They're having another surgery or revision, and their healing is set back. Everything is set back on their timeline. This can help prevent that because they land on the squishy stuff instead of on the end of their limb, right? It's pretty easy to apply, lots of big Velcro. It also has a rigid posterior stay, which promotes knee extension. It's not going to fix a knee contracture, right? A flexion contracture, but if somebody just has tight hamstrings, it'll help stretch them out. And it'll maintain the extension for the people who are weaker and are having difficulty extending against gravity, which is another reason to recommend it. It also comes with a hip belt so that when somebody stands up to transfer, it doesn't just slide right off. And you can wear compression under it. So the shrinker can go under it, A-strap can go under it, post-op dressing can go under it. When is this a good recommendation? For your people who are more likely to fall. So lower level patients when they're transferring, but I would also say I've had a few higher level patients with great ability who made poor choices. And they fell frequently because they just didn't listen. And they got up, moved around, tried to move around without a device, transferred without a device. I had a patient who got around by crawling, which we know is not terribly unusual for our patients, but he dragged his residual limb behind him and tore up his incision line, ended up with an infection. So I really like that particular device for the right patient. Again, it's not for everybody, but know that it exists. If you're really struggling with a patient, they need something to protect them better than just a shrinker. Also, I do want to highlight very briefly a rigid removable dressing. I won't go into great detail on these. These have fallen out of favor just because they take time to make, and it's a little bit of an art project, I'll be honest with you. Where I worked, the hospital where I worked for many years, we the therapists made these for patients. What's so great about this? You fall, this breaks, patient doesn't break. Right? That's all there is to it. And it's cheaper than the stump protector. Gradually, the stump protectors have replaced these, but know that a rigid dressing is an option. It's held on with a supracondylar cuff. Some stockinette goes over it, and it's held on this way. Also know that if you think something more rigid is appropriate for your patient, talk to your prosthetist. They can make these too. They can make them faster than I can, for sure. But there would be a cost associated with this as well. So you would talk to them about what that would look like. That's just my comfort zone. I feel like those protect the patients really well, but it's not always going to be feasible for the patient. Okay, so that's my spiel about compression. I could talk about it for a lot longer, but I want you to know the basics out there. I want you to feel empowered as therapists to lead that conversation, to be getting better compression sooner for patients and understanding how to protect their limb. Also talking to patients about healing. You can't get a prosthesis patient until you've healed. And you can't heal unless you're compressing and doing all of these, following all of these other guidelines that we're giving you. So it all comes together for the ultimate goal, which is prosthetic fitting. Okay, let's talk a little bit about phantom limb pain. Even more so than in acute care, you folks are going to be addressing this with your patient population in post-acute care. Honestly, if you're watching and you also see patients in outpatient who have a prosthesis, this is really good information for you to know. So we know that the majority of patients with lower extremity amputations encounter or experience some kind of phantom limb pain. We're understanding more and more that there's a stronger link between phantom limb pain and preoperative pain. So think about your patients who have been doing limb salvage for a long time, maybe with a lot of pain, or somebody with significant neuropathic pain prior to or related to a diabetic foot ulcer, some other neuropathic condition. So that sensitizes the brain, right? We're understanding more and more in outpatient, especially about pain management and centralized pain. All of that applies to phantom limb pain as well. I think that's really important. So there's some descriptions for you. And there's also some surgical technique that can contribute if nerves aren't managed really well in the OR, or somebody can get a neuroma. That doesn't help either. I will say that a neuroma is not the same as phantom pain, nor is it the same as postoperative pain. Those of you seeing patients later in the process might be more clued into what that's like and how patients describe that. So I like for people to distinguish between sensation and pain when it comes to phantom limb situations. So make sure that you're talking to your patient. Do you just feel your foot and it feels weird or it itches? Or it's actually disturbing you, waking you up at night, painful in a variety of ways. There are all kinds of options there, and allowing your patient to speak openly and freely about it helps them also work through what they're really feeling. And then I think it's incredibly important for us as therapists to include pain rating on phantom pain in our notes as well as post-operative pain. Let's distinguish. Patient, rate your pain on a scale of 0 to 10. What if they tell you 7? How do you know where the pain is if you don't ask? So we can't presume that when they say 7, they mean that it's their residual limb. Not every patient's going to talk openly about phantom limb pain if you don't mention it. So please make sure you distinguish between the two. It helps the patient, I think, work that out a little bit. So some common interventions for phantom limb pain are on the following slides. Please know that this is in no particular order, and these don't stand alone. You can layer on these interventions, and the patient can do multiple of these at the same time. But these are things you could institute in therapy sessions in the post-operative, post-acute care setting. So, number one, guess what? Try not to be surprised. Compression. I said, see previous topic. I think I've beat that topic up. Isometric and isotonic exercises. This might seem a little weird to people. I'm a huge fan of these. What this means, and the patients will think you're nuts when you incorporate these, this means ankle pumps for the patient with no ankle, long arc quads, hamstring sets for the patient with no knee. That's the down and dirty. So I have people doing this sitting on the side of a mat table or sitting in their wheelchair. If they're a unilateral amputee, they have their intact foot on the floor. I think that provides some sensation through their brain to their amputated side. They can also do ankle pumps on both sides at the same time. Mirror therapy comes later in this discussion, but you can do this while you're looking in the mirror. So that's how some of these things work together. Then also sitting on the side of the bed, long arc quads, hamstring sets by pushing your thigh down into the bed and really firing all these muscles. We don't want a max contraction. We're not trying to hurt anybody. When they contract and they're, fewer than 6 weeks out or so from their surgery, they're going to be tugging on some incision. We don't want that. So have them really just gently do those contractions to start to fire those muscles. For the ankle pumps, we know that the plantar flexion is the easiest part, right? Gas pedal. It's the lifting up. It's the dorsiflexion that's a little trickier. I like to cue people with their fingers on the muscle belly of their anterior tib also to make sure that they're doing it correctly. That's another tip. And then here's the wackiest part. If somebody has a transfemoral level of amputation, then I also have them do ankle pumps. They really think I'm crazy. But this is a great exercise program. They can do, you don't have to be with them when they're doing it. They wake up in the middle of the night, they have a big episode of pain, bam, they pound out 20 reps of any of these exercises, even on their intact side, and then they try to get past this particular episode. If they're not having any symptoms during the day, I still have them do it. Maybe they set an alarm on their phone, and every couple hours they do 20 or 30 reps of each one of these exercises. So that might be something that's new to you. What's probably not new to you is desensitization. I zipped past that on the slide. Light touch, massage, donning their shrinker. When they're donning their shrinker or doing a dressing change, that's also desensitization. Our OT buddies are obviously masters at this. I've also had patients tell me that they can massage a part of their leg above their amputation. So for example, if they have a trans-tib level and they're having a lot of phantom limb pain, they find a spot on their thigh that's corresponding with the nerve pathway, and they can rub that and positively affect their pain distally. Or if they're itching, I had a patient who would get a really severe itching sensation in the arch of his foot that was no longer there, and he would scratch his thigh and it made that better. So there are all kinds of different ways to address that. So again, back to mirror therapy. This is one way, long sitting with an apartment style mirror. In the clinic, I love the tall mirrors on wheels. That's where it's at. That you can roll and have it in between somebody's knees when they're sitting up on the side of the bed and they look in and on the side of their intact leg, and then they're doing those exercises. The apartment mirror is a method to use at home. If this really works for them, then they can be doing these exercises at home. And they might need to do these exercises for several weeks or months And as they start wearing a prosthesis, then their phantom limb pain gets less and less. So that's often a really great outcome for them if we can get them to the prosthetic phase. Icing, I mentioned here, we're therapists, right? Let's not forget about ice. That's such a big deal for us. So I mentioned a cryocuff. Our patient liaison, who has a traumatic below knee amputation, when he got home from the hospital, his father-in-law had had a knee surgery of some kind previously and had a cryocuff, so he finagled it to fit the end of his leg and just used that thing throughout the course of the day for some weeks. And he said it made an enormous difference for him. And I'd never thought of that before. I thought that was pretty brilliant. So routine application of ice for him, he said it didn't solve all his problems. It didn't take his pain away, but it tamped it down enough so that he was able to not feel so anxious about it. So that plus his pain medication allowed him to rest in the first few weeks after his amputation when things were pretty rough for him. Kinesiotaping, I mentioned this in the acute care in-service as well, but this is something we might do more in the post-acute care when somebody's healed or healing. If you've got a coworker, if you've taken a kinesiotaping class, you can put your heads together for some methods. I've done some looking online. I haven't found any recommendations because I really don't think there are any. The research is a little iffy on kinesiotaping, but the good news is we know it's not going to hurt anybody. So why not try, right? Why not follow the nerve pathway? Just follow the rules that you learn in the courses about how to apply kinesiotape and just make that work for the residual limb. Don't go over the incision line unless they're well healed and you want to work on scar management. But you can wear kinesiotaping under a shrinker as well. So that's appropriate. And then I mentioned alternative therapies. I've had multiple therapists approach me after in-person teaching sessions to say, hey, I do a lot of mindfulness with my patients or visualization related to their pain, and I get really good results with that. So I don't want to say that can't work for the right person. Let's go ahead and try it and give our patients some opportunities to work on that kind of approach themselves. Maybe even some other kind of meditation, if that's something that's available to them, or medical hypnosis. There are different ways to address it. Okay, phantom limb pain, again, I encourage you to take these ideas, any others that you've used that you've found really helpful, and create your own handout for patients. Because most of these things they can be doing, if they're in an inpatient rehab or a SNF setting, they can be doing those things when you're not there with them and then progressing themselves further. Obviously at home they can do all of these things. Okay, our positioning. We'll talk briefly about positioning. I want to make sure that we don't forget it, although I think I'm preaching to the choir with this because we know positioning as physical therapists for sure. We certainly know about knee flexion when it comes to a trans-tib patient, just as important as a knee flexion contracture for a patient with a total knee replacement. It's incredibly important. There's less of a lever arm to straighten that knee, so the more that we're working on it at the beginning, the better. The more we're educating the patient on how to do it themselves, the better. The more we're applying not just active techniques, but passive techniques to maintain knee extension or gain knee extension, the better. So I have seen surgeons, every once in a while there's a surgeon who decides that a knee immobilizer is the right thing for a patient. I could not disagree more with that. Think about the pressure. Now you have 3 points of pressure. You have, let's say this is somebody's knee, and they're really pushing the pressure on the distal end of their residual limb. Where's their incision line? Right there. So we're really asking for trouble. If you've got a 10-degree knee flexion contracture, pressure point here, you're asking for trouble with a classic knee immobilizer. There's really nothing else I can say about that. If you want to talk to your surgeons about having that discussion, I've also seen them try to put patients in a posterior leaf splint. that they've made out of splinting material. It's not strong enough for a true contracture. It's not going to hold anybody in the right position. Maybe it sort of kind of protects them distally, but only minimally. So there are some things that I don't think are very effective. And I think that's just our opportunity as therapists to really work inside our scope of practice and be working in conjunction with those other healthcare professionals to improve care for these patients overall. So the other thing I want to mention for trans tibs is hip. I can't tell you the number of patients I've seen who have spent a lot of time in a wheelchair. Their healing was delayed. Maybe they've got a knee extension that's in like the picture in the slide on their wheelchair, but they haven't stretched their hips. So they come out and they've got a 30 or 20 degree hip flexion contracture unilaterally or bilat. It's even worse when it's bilat. So in post-acute care is really where we can address that. Prone lying is the best. If you can't get your patient in prone, and I'm not talking about sleeping that way, but just getting them in prone for a few minutes a day, starting a prone press-up progression if they can tolerate it, prone on elbows, really opening them up across the hips. I do that in outpatient. When I get folks in outpatient pre-prosthetic, one of the first things I do is a prone press-up progression. So get lumbar extension as well, right? Getting them better clued into that sooner rather than later is really going to make a difference, in my opinion, in really stretching them out. And then maybe if they can't get in prone, side-lying hip extension, it's better than nothing, making sure that they're not compensating, and supine lying right on the edge of the bed with their limb hanging off so that they're really stretching out their hip flexors off the side of the bed if you feel that's safe for them and you can help them get in that position and out of that position safely. Trans femme patients, hip extension, now that's not a big surprise for these folks. It's as important, if not more so for them, however. If you're lacking hip extension to at least neutral, the prosthetist has to accommodate for that in the socket, and the patient is going to have less power in their hip extensors to control the prosthetic knee. So the straighter they can get, the better, and the more comfortable they're going to be also. If somebody has a mild hip flexion contracture, let's say 5 or 10 degrees, they've been working it pre-prosthetic, then they get a prosthesis and start walking more, their body weight and using the prosthesis might stretch them out more, which is what you really want. But we don't want to wait for that in order to start this process. So again, prone, where possible, is where it's at. We also want to trend towards hip adduction. It's natural to be in an abducted position, slightly hip external rotation. That's going to decrease the patient's ability to generate force in the abductors and standing with a prosthesis. So passively positioning someone out of that position, maybe a bolster along their thigh when they're in bed and supine, anything like that's going to help, I think. And then patient education, of course, helping them to understand that everything they do today leads toward successful fitting and walking with a prosthesis. Okay, moving on from positioning to a little bit more of the things that we're going to be doing in the post-acute care. The acute care therapists have done some transfer training, of course, right? Let's get out of bed to the best of our ability. But in your settings, in post-acute care, that's really where you're going to perfect this. I like to use transfer training as a whole session to have them do something over and over and over again, to really use that for some activity tolerance stress as well, and get them used to using their body to stand up without a leg, to transfer without a leg, of course, to the ability that they are safe. And then in the post-acute setting, I think it's imperative that especially if you're in an IRF setting or a SNF setting, before they go home, we need to be having them get on the floor where appropriate and do floor transfers without a prosthesis. Often we wait until they have a prosthesis, but what if they fall without it? They're more likely to fall without it. Let's go ahead and let them be comfortable doing that transfer without a prosthesis. I've spent entire treatment sessions on this. I think it's invaluable. I've had so many patients come to me saying that one of their primary goals is to be able to get down on the floor to play with their grandkids. But they're afraid to do, they might be able to get down, but they're afraid that they can't get up. Like, well, here we go. We're going to get out the mats. We're going to practice this thing until you know how to do it. It's harder for the trans femme patient because they can't kneel. They can't tall kneel, but they can still do it. So I've had lower level patients be able to figure this out with help. Maybe I've had to give them some notable help the first few times. Then they start to figure it out and we problem solve. So I really encourage you to not skip that step for your patients in the post-acute setting. And then definitely talk about falling. We'll talk about that more in the prosthetic phase, but you might not practice falling, but talking it out with patients. What is it that they're going to need to do with their body if they're going to fall to protect themselves? Patients have, when they start to fall, they have a split second where they're going to remember what you said. So rolling as much as possible, rolling away from their amputated side, transferring that body weight away from the hip, from the greater trach as well, and away from the shoulder, all of those things. That's a whole class in and of itself, is talking about teaching falling. And then exercise progression. This is just a laundry list of positions. I just don't want you to forget them. Let's think about how we train neuro patients, stroke patients. We're doing rhythmic stabilization. We're really working on core, all the PNF stuff. All that applies for these folks. Get them not just in prone, get them in side lying, hook lying. I do a big bridging progression with people unilaterally and have them work on keeping their pelvis straight. I also have them use their amputated side when they're comfortable to try to bridge with off of a bolster. Nothing gets your glutes fired like trying to do a unilateral bridge without a foot. It's pretty powerful. Quadruped, I think we often forget quadruped. For the trans tib patient, you still don't want any pressure on their incision line, which is likely anterior. So a little towel roll under their, just distal to the tibial tubercle to lift the end of their leg from the mat table, or position them so the end of their leg is kind of hanging off the edge of the table. So that might be a way to go about it. Think of all of the core strength that you need for the bird dog progression. Now think about the trans femme patient in quadruped. How much more core control do they need to even maintain that position? And then try to do opposite arm. Wow. And then they can progress themselves as they're comfortable, letting them know that the stronger their core is and the more they're used to transferring their body weight from side to side, even without a prosthesis, the more comfortable they're going to be walking and the better they're going to be able to do that safely. So let's not forget quadruped. Tall kneel for our trans tib patients. Wow, core control there with rhythmic stabilization as well. Also really important. And then anything sitting balance, right? All of the sitting balance things we would normally do, static, dynamic, having them then sit on a foam piece or a Dynadisc, something like that. Anything to really get their core going, getting them shifting their body weight over to their amputated side. They're not going to be comfortable with that. Remember that midline used to be here for these patients. Let's say this is their amputated side. In their minds, midline is now here. When you walk, you've got to get your body weight all the way over there to clear this leg in swing phase. The problem that we have once we're trying to gait train people with a prosthesis is they move their center of mass back to what used to be midline. If they do that in their mind, they're all the way over here. They think they're all the way over and they're just in midline, what used to be midline. So we really want to get them feeling comfortable shifting over there, however we can do it safely. So a lot of reaching over on in sitting with a Dynadisc. This is where I'll get people on a Swiss ball. I know it's kind of crazy, but for people that you think are appropriate, people who can stand up and you on one leg, they've got their walker, you put the ball behind them, they sit on the ball. I always have the ball backed up the first few times against the wall or against a mat table, so that stabilizes it posteriorly. And then I provide any proximal or anterior stabilization they need. I'm right there. They can grab my shoulders if they need to. And they're really working on that weight shifting, core control, reaching. Often I'm sitting right in front of them on a rolly stool, and I'll have my knee blocking their other leg so that they feel comfortable. If their feet slip and slide, that's when I get out a piece of Dyson. Put that on the floor, boom, feet don't slip. So that's something that I've done a lot of to really get people feeling more comfortable with moving their bodies. Also, standing with their knee for a trans-tib patient, their knee on the mat table, raised to the appropriate height. Now you can do a ball toss. You can get them to shift over as long as there isn't any pressure on their residual limb. And then once they're healed distally, then they can start using, if you see on the bottom of this slide, there is the, and you'll see that on your own handout, the 2.0, the iWalk 2.0 is something I used in the clinic versus a knee scooter. That's something that maybe the outpatient folks are going to be doing more when somebody is closer to being ready for prosthetic fitting. But know that that's out there. We just don't want to injure anybody, but if they're healed, they can use that to really start walking around. Again, that's for trans-tib patients. You don't get any knee flexion, so that's awkward, but they can use it with crutches and really start to work on even more on core control. That's the laundry list of interventions. You know the interventions. It's just a question of applying them to this patient population and thinking outside the box a little bit about all of the different ways you can challenge someone with the ultimate goal in mind of prosthetic fitting. So I do want to spend a couple of minutes on prosthetic prescription, even if your patient is not ready yet for a prosthesis because they're still healing. You know they want to know. They're asking questions, and you might not have all the answers. So this is the goal. If you notice here on this first bullet point that better balance, better mobility without a prosthesis is directly linked to better mobility with a prosthesis. It also allows patients to qualify for higher level prosthetic components. So somebody who is very low level is only going to use a prosthesis to transfer in their home is not going to get a very fancy leg, right? They're going to get a really stable leg, which is appropriate for them. But the patients who are much more mobile, who have good standing balance on one leg, can transfer, can do all kinds of other things independently with one leg, are going to get much better components that allow them to be more mobile after they get a prosthesis. So that's another reason to really be more assertive with our care, to really help someone see why what they do in the pre-prosthetic phase is directly linked to what happens to them after they get a prosthesis. And then in the second bullet point, a prosthetist or patient advocate or patient liaison from your local prosthetic company can visit your patient for a consultation that's absolutely free when the patient wants to talk a little bit more about that process. So that person can also provide a shrinker, but the provision of a shrinker and the provision of a prosthetic leg they're separate transactions. So they could have gotten a shrinker from one company, but they're not obligated to use that company to get their leg. Letting them know as they start to feel better, they can interview a prosthetic company and find out if they get a good relationship with that person. This is a long-term relationship that they're going to have with their prosthetist. So we want to let them know that they can talk to as many people as they want, or they can talk to the same person multiple times until they feel comfortable committing or making a decision. At this stage, it's just for learning. Patient, what are your questions? Let me answer your questions. If it's a patient liaison, someone who has an amputation themselves, they're going to be answering questions about what it's like, what was it like for them. That's a really powerful story for your patients to hear. And again, knowing that you can institute a consult without a physician referral, it's the patient choice. I want this person to come visit me. The same is true for your home health patients. And also for outpatients. I've had patients get a prosthetic consultation in the outpatient clinic. So they're pre-prosthetic, they just got out of the hospital. I have the prosthetist come in. I might do my interventions, whatever my appointment was, and then I get them a room. They sit in a room with the prosthetist or the liaison. I go about my business, all is well, and I'm getting them the information they need. So I think that I want you to know that that's an option for your patients. You don't have to know all the answers, but it's also a really good opportunity for you to learn the answers as you're communicating with your local prosthetist. Then this next bullet point follows suit. I encourage the patients to start this process sooner rather than later, and you to start it sooner rather than later. Don't wait for the surgeon, because you don't need to wait for the surgeon. You don't need for the patient to be healed to start having these conversations. And then I mentioned previously related to shrinkers, patients have a choice. That's federal law. That's part of HIPAA, is the patient choice in where they go for their therapy services and where they go for their prosthetic services. They need to know that they're in the driver's seat for that. Which is why we like for them to talk to more than one company. If they interview the first company and they're all about it, then fantastic. Make sure that you talk to your local prosthetists who are sponsoring this course about how they like to do consultations and what they're able to offer you and your patients. And then I mentioned this earlier, that once they're healed, that's when they're ready. And all of these other things need to lead up to healing. I hope this has really helped you get some better understanding of the full picture of all the things you can do with patients in your post-acute care phase to really get them ready for the prosthetic phase. That you have a role, and it's more than just doing some long arc quads or doing some bicep curls. So please be encouraged, and more than anything else, I want you to make sure that you are talking to your local prosthetist about any questions that you have about specific patients you have, and they can, even a case study, and they can give you some information, and you can really establish that relationship with them. So now I'll turn it back over to those folks, to your local team, and they can answer any questions you have right now. Thanks very much. I hope this was helpful for you.